Hello, and welcome to Wellness Wednesday with 3W. Wellness Wednesday is sponsored by 3W Medical for Women, a nonprofit medical clinic offering free of charge or low-cost women's health services in the Seattle area, regardless of income or insurance status. 3W does not profit off of the health choices women make. The information shared in this podcast is the opinion of the speaker or speakers. Medical information is not intended as individual medical consultation, but for general education only. Always talk to or consult your own health professional for personalized advice regarding medical decisions. And if you're in the Seattle area, consider making an appointment to consult with us. I'm Helen Nguyen, CEO of WAMS/3W Medical for Women, and the host of today's podcast. Hi there, Wellness Wednesday listeners. We're back in the studio, and today we have a guest speaker, but they're not really
a guest.
Yeah, not really a guest. She's been on here plenty of times, is our dear friend, Dr. Susan Rutherford. And I love it when she's in the studio because I know it's going to be a riveting conversation. And I wanted to call this podcast kind of like a myth-busting podcast because we're going to be talking about 3 different topics that pertains to reproductive health, sexual health, and who better to speak about it than our very own Dr. Rutherford, and because she has such a pulse on these kinds of things. So, okay, Sue, what is the first thing you wanted to touch today?
So one I want to mention briefly is I finally looked up the entire package insert for the mifepristone, which is the chemical abortion drug, the first of the 2 drugs.
Yes.
And the FDA has 2 forms that are required for the patient to read, and one of them at least they have to sign.
Oh.
But yes, it's part of the package insert. And people are ordering this stuff online. How do they know that patients have read and signed these basically informed consent?
No one
that's
reads.
Made by the FDA, required by the FDA.
Okay, no one reads the inserts.
I know, but
Because
they're fine print. It's
I
like
know.
it's like when you go in and you sign something. I mean, it's meant to be read. So
Informed consent.
Informed consent. Informed consent is getting to be a bigger and bigger deal.
Right.
And it's not just telling people what you think they need to know.
Yes.
It's having a conversation now.
Yes. And it's a conversation that's back and forth,
Yes.
allowing the patient to ask
Yes.
questions that might seem obvious to the expert,
That's
but they're
right.
allowed to ask those types of
Yes.
questions.
And that's the safest and most real kind of informed consent.
Yeah. It's like going and getting a prescription at the pharmacy and them going, "Do you want me to explain this to you?"
Yeah,
Right?
you know, that's always, I say yes.
Yes, I always
say
do
yes.
that too, even if I kind of know.
Do you know
But-
there are certain foods, if you take the medicine soon after you eat this particular food, then there's going to be a reaction, or you can take it before or after this
Yeah.
other food and it'll
Yeah.
be okay. I mean,
Yeah.
there are all sorts of details
Yeah.
that you should know.
Right.
Yeah.
Yeah. Okay. Well,
Okay. Informed consent.
Informed consent. All right.
Okay.
And then, the next topic you wanted to talk about was this new
Syphilis over-the-counter test.
Yeah,
Yes,
over-the-counter
yes.
syphilis test.
Yeah, so the FDA just put out a news release on August 16th, and you can get it in Spanish as well as English,
Okay.
probably other languages too. But it basically, they allowed marketing of an over-the-counter syphilis test.
Okay.
And so this has gotten into some of our, sort of informal medical literature and that sort of thing. But the main thing that they're touting is that way people can buy it and they can do it privately. They don't have to go through insurance. They don't have to get billed. The fact that they had a syphilis test doesn't have to go in
some sort of record.
the big server in the sky.
Yeah. It's not documented
It's
somewhere,
not
right?
documented somewhere. No,
Yeah.
that's right.
Yeah.
And I want to talk about the syphilis testing because that's only one step, and there's some limitations to that.
Of course. Yeah.
So I do want to go over that, but I want to point out that many of the reasons that people come to 3W is because we do not bill insurance. They pay cash, credit card, whatever, for the lab costs of these tests. So a syphilis, I think, is it's a blood test. I think it's $11.
Yeah, under $20.
Yeah, really cheap.
Really cheap.
And
yeah.
the other tests similar, the other STD tests. So they just pay out of pocket, and they don't have to, it doesn't go to their insurance. It doesn't, if they're in college, it doesn't go to their parents' insurance, who get mailed the explanation of benefits that says there was this and this and this and this done,
Right.
et cetera. So, so there's lots of privacy. If people come to 3W, they get that same privacy.
Yes.
So, and, this is approved by the FDA. I'm not. Sometimes FDA approves things you wonder about, but it's probably fine. Yeah. Syphilis testing is not just one test. So it's caused by a bacteria called Treponema pallidum. Okay. And the testing, there's two general sets of testing for that. One is to look at your body's immune response to that infection, and the other is to look for the signal that comes from actually that bacteria being around there. Okay. So the test that's most commonly done for screening is to look for an immune response. And it's called a VDRL, for Venereal Disease Research Lab. It's called a VDRL, or an RPR, reactive plasmin reagent, something like that. I can't remember. But anyway, an RPR. Those are basically the same. And that's usually what's done. So if it's required of all pregnancies, because if a mom is found to have syphilis, she can be treated with an antibiotic, and that antibiotic, the penicillin, crosses into the baby and prevents the baby from being born with congenital syphilis. Wow. And this is a big deal because there's been a significant uptick in our country in congenital syphilis.
Yes, syphilis is on the rise,
It's
remember?
on the rise. Yeah. And especially the congenital syphilis, you're causing brain damage even before the baby's born.
Wow.
So, in fact, as I was reading a little bit to do this podcast, I thought that brain damage from syphilis occurred after a long period of time of being infected, et cetera. It can start really early in the infection. It's like, oh my gosh.
Wow.
So people need to not take this casually. Yeah. It takes a while for your body to respond with an immune response. It takes maybe 90 days, so maybe 3 months. So people that were exposed last week, they probably need to wait a little while before getting the test done. Wow. If they decide to do it in like 6 weeks, because that could be positive. Yeah. And it's negative, they should do it again. Okay. So when at least 3 months from their exposure has gone by. Yeah. Just to be sure that there's not a false negative on that.
And what are the symptoms for syphilis again?
So initially, there's sort of, it's called a chancre, CHANCRE. Okay. It's sort of like a little sore, like a little tiny rash. It's not painful. Okay. It's usually where the bacteria entered the body. So from sex, it's usually near the genitals. Yeah. Okay. Yeah. But it could be lips, could be other parts of the body. And then it becomes quiescent, latent for a while. The infection, that chancre goes away, and then later you might get a rash on the soles of your feet or the palms of your hands. Wow. Yeah, and then eventually, you may get brain damage from that. They need to, so at some point, if you've had it for a while, if some of this testing is a problem, you might have to have a spinal tap. Whoa. Because that's the only way of knowing if that got into the central nervous system. Wow. Yeah, because the fluid that they get with the spinal tap originated in the chambers of the brain and then cushions the brain, goes down around the spinal cord. And so they test that to see if it's there. Do you remember the movie or the PBS about, wasn't it Queen Elizabeth? The young one who came to the throne as a teenager, basically. Do you remember there was a PBS special and she marries a guy from Germany who's a prince from Germany? Do you remember that? Okay.
No, I don't.
Well, that's long ago history, but it was really pretty nicely done. I didn't see all the episodes, but okay. But this prince from Germany was a virgin. His brother was not. His brother was well known to the prostitutes, etc. And so before this guy gets married to this future queen of England, or actually maybe she's queen by that point. Anyway, he takes the prospective groom to to a high class house of prostitution. And so the groom doesn't do anything. He talks to the lady. He asks her for information. So he doesn't actually have sex with her.
Yeah.
So, but this brother then comes with him, is in England. He falls in love with a lady in waiting, etc. And he's going to ask her to marry him. And he's been to the doctor to make sure everything's clean. His valet is helping him dress. And he's facing the camera. And the valet's helping him put his shirt on and says, "What's this rash on your back?" And you can see his face visibly just collapse. And the next thing you know, this lady in waiting who's expecting to be treated to a lovely dinner gets a note. "I'm very sorry, I had to return to Germany suddenly." They never said anything, but you know very well that's syphilis.
Wow.
And it's just like, yep, that's what used to happen pre-antibiotics.
Oh, wow.
The main treatment is penicillin. Actually, the only real treatment is penicillin. And certain types of penicillin, and it can't be taken as pills. You have to get it as shots or IVs or something.
Oh, wow.
Yeah, so it's certain type of penicillin because that type of penicillin needs to be able to penetrate into the central nervous system, into other body cavities where the bacteria could hide. And so if somebody's allergic to penicillin...
Yeah, I was going to ask, what if someone's
what
allergic?
Happens? They go through a sequence of steps to try and decrease their immune response. So they go through little shots, periodic shots, to make them so that they don't react. They don't have a bad reaction to the penicillin. So that they can be treated with the penicillin.
Wow.
Yeah. So
it's
like
serious.
People get, it's very serious. It's very serious. Yeah. So it's like, kids get treated for allergies. They get the sequence.
I was just going to say allergy shots.
I got that when I was little. Yeah. The allergy shots. They do that to get them so that they can be given the penicillin. But anyway.
So how will this over-the-counter,
how is the over-the-counter? Where does that fit in?
Yeah, because when patients,
first step.
So when patients come in to 3W, they get a blood draw.
Correct.
But over the counter, how do you do that?
So the at-home test, there's you poke finger and put on a drop of blood, and it gives you the answer like in 15 minutes. So it's the test for the immune response for the antibody.
So it's probably like a diabetic poke,
yeah, like a diabetic poke. Yeah.
Oh.
Yep.
I do not want to do that at home by myself.
Well, diabetics do it multiple times a day.
I know,
unless they have the continuous glucose monitor.
I know, but it still kind of freaks me out. I don't want to do that.
When you do pokes, do them on the side of your finger, not on the pad end.
Oh.
It's less painful.
Oh, okay. There's a little tip.
Yeah, there's a tip.
Okay.
I learned that from the diabetics that I took care of.
Okay, so that's how the over-the-counter syphilis test is going to work.
Yes.
And I guess you poke your finger, you do
Probably
the little
finger, yeah.
Yeah, and then you send it in to the mail?
No. It says within 15 minutes.
Oh, so it shows the results right there.
Yeah, so it's like a home pregnancy test.
How accurate is it, I wonder?
Well, it's probably pretty accurate, except that there are false negatives and false positives. So the false negatives are, it hasn't been in your system long enough to generate enough of an immune response to make the test positive. Okay, that's a false negative.
So if you're getting it over the counter, is anyone explaining that to you, I wonder?
Well, it should be a package insert. Read the direction. My father used to say, if all else fails, read the directions. Yeah.
Right? But if you're in a panic,
you get it negative. Well, it's negative for now, but you need to recheck.
Okay.
Yeah.
If those symptoms are showing.
Certainly if you have any symptoms, if you're worried, recheck, Yeah. I would think that they would have compared it to get it approved, they would have compared it to the actual blood draw tests.
Yeah.
Yeah. I wonder how many clinics are just going to purchase that.
I wonder if it's
and
cheaper.
Do it in their. It might be cheaper. I don't know, but clinics could purchase that and do it in their clinics. It might become one of the, accepted labs that you can do in a clinic without having to have a specialized lab permit.
Does syphilis have different strains like HPV does?
No.
Okay.
No.
Okay.
No.
Because I'm wondering,
So-
because if it's different and it
No.
says -1,
No.
but you're not testing the 70 other strains or something like that.
Just the one.
Okay.
Yeah, just the
Okay.
one. But again, it's testing your immune response. So there are people that have gotten positive syphilis tests.
Mm-hmm.
They had it drawn routinely because they're pregnant or some other reason, and it comes back positive. Well, then they go to the specific test, which is there evidence of that actual bacteria in your body?
Okay.
Is the treponema
Okay.
pallidum bacteria there?
Okay.
Because, and if that's negative, then you start doing all the other autoimmune tests. You know, could you have lupus? Do you have any of the other autoimmune diseases? So some people have gotten diagnosed with lupus because they had a positive syphilis test, and the workup didn't lead to syphilis. It led to, you've got an autoimmune disease.
Oh, wow.
Yeah. So that's the false positive part of it. Then the treponema one, that may or may not stay positive. The antibody response will probably always be positive.
Okay.
But once it is, but you know, one of the problems they have, although they can use these different tests to try and monitor the treatment response. So, you know, it gets complicated, and we don't do that at 3W. We will order the confirmatory test, but then we are going to refer somebody to a clinic that will actually do the workup. You really need a good syphilis-specific physical exam. You might need brain imaging. You might need a spinal tap.
Wow.
You know, there are lots to the workup.
Yeah.
So all we'll do is do these initial blood tests
Well, I'm just wondering.
and look at you if you have a sore.
Yeah. Yeah.
Yeah, because you can get, if you have a sore, you actually, that's the most accurate.
Yeah.
Is you do a little scraping from that sore and put it on a microscope slide, but it has to be done what's called dark field microscopy, and we don't have that ability.
Yeah.
So, but that's the most accurate for do you have syphilis? That's 100% accurate.
I wonder.
Well, 100% if it's positive.
Yeah, I wonder if the inserts have all this information. I feel like that's the downside of this over-the-counter syphilis test,
Yeah.
is that people are not going to be educated about
I don't know.
safety around.
Well, the
Sex, right?
FDA says to a company, this is what you must put in your patient information. So hopefully somebody's watching the store and doing that properly and in a way that's understandable. If you go, you know, one of my favorite places for this is the CDC, Center for Disease Control, cdc.gov. And so that has a lot of this information. And they have it in lots of readable formats. They have it for medical professionals, which anybody can access. They have it for people that aren't medical professionals in a variety of different languages.
Right.
And so I'm a big fan of what they've done for patient education. So
Okay.
I'd recommend going to cdc.gov, but it takes time. Got to do your research.
Yeah. I don't know. I'm one of those people that I rather just come to a clinic like 3W and do it, because you might be interpreting it incorrectly, you know, because coming from a non-medical person, I would like it to be more conversational and educational that way, because you might miss something, or I don't know.
Yeah.
It's
well, you know, we do a pregnancy test on every patient that comes in. And our pregnancy tests are probably, I mean, that you can get over-the-counter ones that are probably similar or maybe as good. I just don't know which brands they are.
Sure.
The one we get comes from medical supply, and they have to meet regulatory requirements. So these things, being a medical grade one, what we can say is this is as good as it gets.
Right.
I'm sure there are some others out there.
Yeah.
But when companies are testing their drugs to market, if it's an IV or whatever it is, they test for shelf stability. Does it have to be frozen like some of the COVID vaccines? Is it safe at room temperature? How long does it stay active? Does it last at room temperature? Is it a month? Is it 2 years? Is it, your expiration dates on things? Basically, what the expiration date says is this is as long as they tested. So they figure people are going to use it within a certain period of time, and it costs money. It costs thousands of dollars a month to test each batch of a drug.
Yeah.
Thousands of dollars go into that. So part of our drug price is the ongoing testing by the companies that sell it.
Okay. Well,
funny all this trivia you learn.
I know. Do you know how much the over-the-counter syphilis test? Did it say in the article?
No, it didn't.
I wonder how much it is because, I mean, our price of $11, it's kind of hard to beat.
I was going to think that's probably pretty hard to beat. Yeah.
I know.
I mean, the COVID test, what are they charging? $14 more?
I don't remember.
I think it was, definitely more than what we charge for and we don't charge for the actual drawing of the blood.
Exactly.
You go into a lab or something, they charge you $15 or $30 or something.
Right. Because that person has to get paid.
The person has to get paid that's doing the blood draw because our staff are paid by our wonderful, generous donors. The actual blood draw fee is not charged to the patient.
Right.
Just the lab processing cost.
Exactly.
Yeah.
Yeah, we're not attaching a whole bunch of different other price tags onto that $11. It is literally what you get.
So I bet it's cheaper than this.
Yeah, I was gonna say that's a pretty premium type of.
Maybe someone can go buy one and come tell us.
Yeah, let us know if you ever get one and see how much it costs. So very interesting stuff. Okay, moving on to the next topic is this article that was released by the Seattle Times on August 12th. So a very recent article titled "Dozens of Pregnant Women, Some Bleeding or in Labor, Are Turned Away from ERs Despite Federal Law." And Dr. Rutherford, I know you are very passionate about this topic because it is misleading.
It is misleading. It's completely misleading.
Okay, how so?
So they are trying to put out there a story, a narrative that's going to get people all worked up.
Yes.
And unfortunately, they're lying. There are so many lies associated with this. And what the reason is because since Dobbs' decision, various states have put restrictions on the performance of abortion within their state.
Yes.
And they are trying to get people to think that those restrictions are harming women.
Yeah.
And it's not true. It's just plain not true.
Right.
The stories that are in the Seattle Times article about people not getting treated for ectopic pregnancies or intrauterine infections, those are stories of malpractice. I don't know a single OBGYN who would do that.
Right.
Yeah. I mean, I've never heard personally from an OBGYN saying, well, I didn't do this because I was worried about getting prosecuted for, for breaking an abortion law. I have never heard that. Their stories point to emergency room doctors.
Yeah.
My experience throughout my decades-long career is that people that aren't in OBGYN or aren't familiar with taking care of pregnant women, some family docs take care of pregnant women.
Sure.
They're allergic to pregnant women.
What does that mean?
If a pregnant woman comes into the emergency room or goes into the urgent care or whatever, and they say, oh, pregnancy, I'm not really well versed on pregnancy. I don't know what to do.
Right.
Well, they just kind of panic and their eyes glaze over and they don't use their brains, because frankly, most things having to do, though you go to an emergency room or urgent care that are not pregnancy related, are treated exactly the same if they're pregnant or not. If they have a broken leg, if they have asthma, the treatment for asthma is exactly the same.
Wow.
So seizure disorders is one of the few, but that has more to do not with the immediate treatment of seizure disorders is the same. The long-term control of a seizure disorder by a neurologist, that may be slightly different, the choice of medications, because some of those medications do have adverse effects on a developing unborn baby. But almost everything's the same.
Yeah.
You know?
Yeah. Maybe because they realize there's 2 lives at stake.
Well, it's very interesting because our own state recognizes that. Medicaid recognizes that. When you apply for health insurance, if you're pregnant, say you're a single mom, or you're just by yourself, you're a solo person, you're a woman, you get pregnant, and you're living by yourself, or even you're living with somebody you're not married to.
Sure. Yeah.
You want to get Medicaid. And it's very generous when somebody's pregnant because they realize that this has long-term consequences for the cost of the health care, not just for the mom, but for that baby for decades going forward.
Yeah. Yeah.
So pregnancy is more generously allowed as far as an income allowance than non-pregnant. So when you sign up for Medicaid on the website, they ask you, are you a household of 1, 2, 3, 4, 5, whatever. If you're pregnant, you're a household of 2 per our state law.
Wow.
They know it.
Yeah. It's fascinating, isn't it?
It is. Okay. So where were we? Oh, I want to talk about the lies about this maternal mortality.
Please.
So I was trying to track down some of the data I read a few years ago, and I know it had to do with Chile and some other South American countries where abortion was illegal. And it was, and some places in Africa too, where abortion was illegal. The claim was by some of these international organizations that try and promote what they call reproductive health, family planning, et cetera. Really, they're promoting abortion. They'll let somebody give birth in the dirt outside, but you can go into a clean clinic for an abortion or get a Nexplanon or IUD put in.
Right.
But the woman who's actually giving birth has to do it in the dirt.
Yeah.
In the building next door. But anyway, so they were trying to say that if abortion is illegal, maternal mortality is worse.
Yes, it's going to rise.
It's not true. It's not true internationally. And now there's U.S. data. It's not true.
Wow.
There's good U.S. data looking at a number of states that, in fact, since Dobbs, and it's a lie that maternal mortality has increased. In fact, some of it's gotten better. Yeah. So that's, first of all, that's a lie. And that's what they're trying to build on with this Seattle Times article. They're trying to do that. They're also trying to claim that miscarriage management is now limited. So that's not true. Okay.
How?
Abortion's been defined a lot of ways, and there's a medical use of the word abortion, which simply means the early ending of a pregnancy prior to 20 weeks. Spontaneous, meaning it happens on its own. Missed abortion, meaning the baby's died, but the pregnancy, the embryo or fetus and the placenta that hasn't actually passed yet, that's called a missed abortion. Inevitable abortion, which is where there's bleeding, the cervix is open, it hasn't actually happened, but there's no way of stopping it.
Right.
Okay. So those are the technical terms.
Okay.
But most of us in medicine are using the word miscarriage now to be distinct from the use of the word abortion, which everybody assumes is ending a pregnancy intentionally. So for me, when I am dealing with that word abortion, the whole purpose is making sure there's not a live baby at the end of this. That's what I mean when I say abortion now. Okay. If it's going to be one of those medical things, I'll use more words and go into more detail.
Sure.
But otherwise, general abortion, the use of the word abortion, and certainly in the newspaper and things like that, that's the intentional ending of a human life that's not medically required. There are some rare instances. They are rare.
Right.
Some of the things they're saying are not rare, are like if the membranes rupture, say the membranes rupture at 16 weeks. I have had, of all my career, I've had so many women beg me at 16, 18, 20 weeks with ruptured membranes, please don't end my pregnancy. Isn't there some way of waiting this out? And I'll say, yes.
Yeah.
But if an infection develops, because now with the ruptured membranes, some of the barrier to infection, there's some antibacterial properties in the amniotic fluid.
Sure. Yeah.
But unless this kind of seals over a bit, there's a really high risk of getting infected. As soon as you show any sign of infection, I'm sorry, but we're going to need to induce your labor, or, the pregnancy is going to have to end. Yeah, because there is no way that baby's going to survive,
but
even if you tried. But
there are things to do before that.
Before there's infection, if the membranes have ruptured, I've occasionally had women say, yeah, I think I should just go ahead and get it over with, because the risk of infection is extremely high. The chance of the survival of the baby is extremely minimal. And yes, there's not an imminent risk to the woman's life, but there is a risk to her life. But during my career, the patient that wanted that was rare. Almost all of them were begging, can't I please wait? Because there are situations when membranes have ruptured in the second trimester, which is prior to 24 weeks. And babies have made it to survive and survive healthy. That can happen. And I've had far more women, maybe their cervix is starting to dilate early, incompetent cervix, or some preterm labor. Isn't there something you can do to stop this, to interrupt this, to prevent my baby arriving now at 21 weeks? I had a patient in St. Louis once. In fact, we still exchange Christmas cards and Christmas letters. Twins.
Wow.
She herself was a medical person. Her husband was a physician. And I met her when I was helping cover at a university hospital in the middle of the country.
Wow.
I flew in to cover for a week or two now and then just to help that department out because they needed extra warm body. And I was sort of a little bit footloose and fancy free, so I'd go do that. And so I met her, and we spent probably 2 hours at the bed. She's in bed there in the hospital talking about all the different things that could be done, what might happen. Well, fast forward, I've come back, a couple months later, she's still in bed in the hospital and things are stable. I come back, let's see, she started out at like 21 weeks. I come back at 35 weeks for her. Her 35 weeks. So how many weeks? I mean, that's 14 weeks she's been in the hospital. That's over 3 months.
Oh my gosh.
At bed rest in the hospital.
That must have been so hard.
And she just had her twins the day before.
Wow.
It was so exciting. And they were they were only 34, 35 weeks. So they were in special care nursery. But they were doing well. The twins are now in college, I think.
Oh, geez.
I know.
That's amazing.
It's been a while.
Yeah.
But I said, this was a huge commitment. Why did you decide to do what you did? She said, because you never told me it couldn't be done. You never told me it couldn't be done. So I find in my entire career, I've met thousands of women who wanted everything to be done compared to the relative few who were inconveniently pregnant and wanted to end it. There's so many more.
Yeah.
And I don't think the newspapers and everybody, they're trying to portray this as if abortion is one of the most necessary things.
Yeah.
It's just the opposite. There are people that really, really want to have babies that are struggling.
Yeah.
Can't get pregnant, can't continue the pregnancy, have multiple miscarriages. It's just really sad. So miscarriage management, you want to go to that?
Yeah. Well, I just, as you're talking, I just wonder, why aren't these patients giving the full picture, right?
Well, it takes time.
Yeah,
you have to sit down.
That's what I mean.
You have to sit down and actually spend some time talking with them. Right. And in fact, that's one thing that's been so much fun. I'm a volunteer. I joke with people. I say, I'm retired from the paycheck.
Yeah.
Some of the most fun I've had while doing a subspecialty where my focus was on significant complications, I made time. The busy OBGYN, boy, it's really tough.
Yeah.
And especially with the way our financial medical system.
Oh, yeah, the billing system, the insurance.
All of that stuff, it's really, really tough.
Yeah.
So one of the most fun things I've been doing with my life is coming in here and meeting. Now it's with just few people. It's just several patients. I'm not
Right.
doing the regular checkups and stuff. Fortunately, we have a wonderful team doing that.
Yes.
But I've been given the opportunity to come in for certain patients and to spend my time sitting with them and talking with them. And it's a real privilege.
Right.
It's totally a privilege.
Well, because that's what you're meant to do as a medical professional is educate and really, again, informed consent.
Yeah,
give
informed consent,
Give the
yes.
patient the full picture so that they walk away
Yeah.
going, I made the best decision for my health care and my body.
That's
right?
my main concern with people is I want you to work hard at making this decision.
Right.
Don't just take it casually.
Yeah.
A
Critically.
recent patient said, "Why is this taken so casually?"
Yes.
You know?
Yes.
And it's like, no, it shouldn't be taken casually because you can never unknow.
Right.
You can never unlearn something.
Yes.
And so you'll never unknow the fact that you got pregnant.
Yeah.
Regardless of what decision you make, that fact will never go away and you'll never forget it.
Right.
So how do you want to think about it 5 years from now or 25 years from now?
Yeah. And creating a space for an individual, regardless of what they're going through, to sit through that conversation. It's critical.
It's absolutely critical.
So when articles like this come out, it just creates panic. It
Yes,
creates this.
that's their goal.
Yeah, it creates this bias approach to saying access to abortion is necessary because she needs to make that decision quickly.
Yes.
But in your opinion as a medical professional, it does not have to be
That
this
quick.
and urgent
as they're
portraying.
So when patients come in here, we tell them everything about their gestational age. They can watch the ultrasound. They don't have to, but they can watch, and they'll see what's there. They'll see the measurement. The measurements explain to them what we can see. If they're 8 weeks, we can begin to see arms and legs and wiggling. You know, if it's 6 weeks, it's you're looking at something that's 3 or 4 millimeters.
But it's there.
But it's there.
It's developing arms
and it's got
and
a
legs.
heartbeat.
Yeah.
And so we will explain whatever they want explained before we finish doing the ultrasound. We'll say, before we stop doing this ultrasound, are there any other questions that you have before we stop doing this ultrasound that you want me to continue, especially if it's a transvaginal, because you don't want to have to put it back in.
Right. Yeah.
But to make sure they've gotten all their questions answered.
Yeah.
So if the gestational age pertains to an abortion choice they might make, then they need to know what's safe, what the statistics are. Supposedly it's okay. It used to just be okay through 7 weeks, the medical abortion. Now it's through 9 weeks. When you hit 10 weeks, supposedly it's not. But there are plenty, they're saying, oh, no, you can do it beyond that. You get into that end of the first trimester, early second trimester, you're going up to a third of those are going to fail.
Yeah.
And they're going to need a surgical abortion, So, people need to know what are the options? What's the timing for making this decision? If I wait, what are my choices? That's important information.
Yes, and it should be discussed.
And it should be discussed, and they shouldn't feel pressured to make the decision.
Well, what's your opinion about the abortion pill that you can access online through telehealth, right?
Oh, that's so dangerous.
How many patients have we seen that do not know when they got pregnant?
Oh,
and they're they think they're tracking their period correctly, but
they're not. I would say more than half. More than half. So that's my gut feeling.
So so the safest route is to come into a facility like ours, a clinic like ours.
Right, because they can't get into an OBGYN for 2 months.
Exactly.
Yeah.
And we can get that. And we can get you in pretty quickly. Much quicker than your average OBGYN appointment. And you can really have accurate information in the sense of how far along are you?
Yes.
Then you can start from there. But if you're guessing at home, looking at your calendar that you didn't update.
I met a woman whose husband ordered it online.
Oh, boy.
They were in the process of getting divorced. This is now a public story.
Okay.
And I met her because she was telling her story in a public place. And he ordered the stuff as a man, which probably just lie and say you're a 22-year-old girl or something.
Sure.
I mean, how many times does do people get taken advantage of that way? Children,
yes,
yeah, all that stuff. Anyway,
it's so readily available.
Yes,
so.
Yeah. So, but he decided that he'd be a little kinder to her than their impending divorce, and he'd fix her breakfast in bed, and so he would bring her, the orange juice or water or something to drink, and he had mixed it into that.
Oh boy,
he had mixed it into that. She had the first morning she had a little bit to drink. She felt a little bit of cramping.
Yeah.
And their relationship was falling apart, so she didn't trust him.
Yeah.
Fast forward, the FBI get involved. They put a hidden camera in the kitchen, and they catch him doing this.
Yeah.
Mixing this in. He only spent a short time in prison, but wow. She has a lovely daughter. But that's the sort of thing that can happen. So people need to be really careful.
Yes.
And they need to, just don't panic. They shouldn't panic. If they have needs, please.
Yes.
Come talk to us, because the number of women who really want to for themselves and the pregnancy is pretty small.
Yeah.
It's pretty small.
I've never met anyone that wakes up going, my goal today is to have an abortion.
Yeah.
We've met countless of women that have decided to go that route because they felt like they have no choice.
Yeah.
But in the reality of things, have they really considered everything? Are they being pressured?
There are some really tough situations, and that's what my career was.
Yes.
People that are on certain medications that might be dangerous to the baby.
Yes.
People where the baby has something that we're pretty sure is going to be a serious birth defect, developmental problem, or something like that.
Yes.
Those are extremely painful, difficult situations.
Yes.
There are answers even in those situations, and for helping someone carry the burden, or someone else volunteering to carry that burden for them. Lovingly.
Yes.
Lovingly.
Yeah.
There's no absolute closed door.
Yeah.
There is none.
Yeah.
So the this miscarriage management stuff. So the mifepristone is the drug that's used to compete with the progesterone receptors to cause the placental tissue to die off, basically, to try to start that process of the pregnancy dying. When that happens, there are other biochemical and hormonal things that start happening that prepare the uterus to evacuate itself. That would happen naturally if a baby died.
Right.
If a pregnancy died.
Yeah.
But you're trying to speed this up over just a couple of days. So most of the time people take the mifepristone, and then you can take it right away, but it's probably more effective waiting a couple of days and then taking the misoprostol. And misoprostol is a drug that's been available for a long time because it's used for some gastrointestinal issues. Okay. But it causes contractions. It causes smooth muscle contractions, including of the uterus. It's been used by itself without the mifepristone to try and induce labor. To try and induce an abortion in the second trimester. When the mifepristone isn't going to be as effective at getting things started, but just to start contractions. So that can still be used. The mifepristone, if it's available, that can be used when there's already a dead baby, and that helps speed up the process to cause the evacuation. When I was trained back in the late 70s, early 80s, we were taught, well, basically you have to do a D&C for all the miscarriages, or you're never assured that it's completely finished. Okay. That's not true. And just, I wasn't that many years later that we realized, hey, you can just wait.
Yes.
It may take a few weeks. Yeah. And occasionally it takes kind of a long number of weeks. Okay. But, and people say, I give up. I just want a D&C, or I want to do something. This is taking way too long. But most of the time it happens within 2 or 3 weeks.
Because you're allowing your body.
You're allowing your body to
naturally
work. That has a benefit. Course. Yeah, by the way, that has a benefit on the other tissues that are sensitive to hormones, particularly breast tissue. And that's where some of the controversy about breast cancer comes in. You know, if that normal hormonal pattern, which leads to a quiescence, a fading of the hormonally triggered stuff, a dropping off of the hormonally triggered stuff in the breast tissue, because as soon as you start getting those hormones, your breast's going to think about, ooh, I better start getting ready to make milk, you know?
Yes.
So that process has to slow down. Taper off.
Yeah.
When you just interrupt a pregnancy really quick, that taper off process doesn't happen the same way.
It just kind of ends.
That's right.
Abruptly.
And there's actually publication came from a Fred Hutch researcher here in Seattle that showed that difference and showed that there was reason for concern that could be a trigger for breast cancer. So that, you know, the people that are putting out, you know, American College OBGYN, all these other people that are very pro-abortion are saying, oh no, oh no, oh no. But it hasn't been disproved, and there's some good data.
Right.
So people need to think about that. But
yeah, I mean, going through a miscarriage, I've never been through one, but I'm sure you just have to make the best decision.
You can,
that you can as for you yourself as the individual, right? We can't make blanket laws or blanket statements or blanket articles, that coerces or create panic in people, right? And sometimes, yes, letting your body run its course might be the best way of honoring that miscarriage process. If you wanted to speed it up, again, did you get all the information? Did you weigh all the information before you do that? Because sometimes going through miscarriage is psychologically and mentally really challenging for some folks, right?
Yes. Now, it's kind of crazy that the FDA allowed this over-the-counter, online stuff. And yet I think it's still the case that if a OBGYN wants to prescribe it, they can't just write a prescription for mifepristone. They have to register. So why is the FDA letting this happen over the counter and making valid doctors that might use it for miscarriage register? Because there's some doctors that don't want to register because it looks like they're providing the abortion pills. Yeah. And so some doctors don't want to be seen that way.
Yeah.
So, but it's too bad, but they might use it for a miscarriage.
Yeah.
You know? So that's the one situation where there's a bit of a glitch. I expect at some point that would get sorted out. But otherwise, the other treatment for miscarriage, there's absolutely no restrictions. Absolutely none. Yeah. And certainly for ectopic pregnancy. Now, the issue of ectopic isn't easy to diagnose. That can be true. But it's other than this about 1 in 30,000 or maybe 1 in 50,000. I'm not sure what the statistics are now, but it's pretty rare. You can have twins, one ectopic and one in the uterus.
Oh, wow.
Yeah. But I've seen one in my entire career.
Yeah.
And that, but so that, and I've heard of, and that's the only one I've ever heard of.
Yeah.
And I've been exposed to thousands of pregnancies, thousands and thousands and thousands through other doctors who are sending me their patients and telling me about their patients and medical meetings and all of that. It's so rare.
Yeah.
And so if I see a gestational sac, and there's tons of medical literature to support this, if you see a gestational sac, that early little 3 or 4 millimeter little bubble of fluid in the central part of the uterus, in the body of the uterus where it's supposed to be, you can basically rule out ectopic. Yeah. And that will happen like 4.5 weeks.
Wow.
So right after you've missed your period, you have a good chance of seeing a really early gestational sac.
That's amazing.
So, most people don't even figure out they're pregnant until 5 to 6 weeks.
Right.
Yeah. And certainly 5 weeks, they start getting symptoms, breast tenderness, I feel really tired. Et cetera. And so as early as you can see that gestational sac, that's when people are getting the symptoms. They come in, find out, it's in the uterus. Definitely women should do that before taking the abortion pill.
Yes.
Definitely.
Yeah.
Because if that's not figured out, because if you've taken those pills and then you go for an ultrasound and you don't see a gestational sac, well, was it there? Is it an ectopic? Then you might be confused and somebody might have to go through laparoscopic surgery to see if there's an ectopic or not.
Oh, geez.
You know?
Yeah.
So you need to get that ultrasound before you take the pills.
Yes.
And if somebody does the ultrasound and says, yes, it's in the uterus, then you know.
Yeah.
If we don't see a gestational sac, and I saw a patient which I thought, oh gosh, there's blood in her belly because there's all this fluid pooled down there, and I can't find that gestational sac. Oh gosh, she may have a miscarriage. And I've been wrong in thinking somebody had a miscarriage and they didn't.
Yeah.
Even a little further along.
Mm.
And so yeah, that's possible. But there are ways of sorting that out over a couple of days when it's still safe enough to somebody's not going to die from that early of figuring out if it's an ectopic or not, because it doesn't rupture and bleed really heavily internally until it's a bit bigger.
Yeah.
So you can definitely find it out in the 2 or 3 days it might take to sort that out with blood tests and the ultrasound and all of that.
Yeah.
So this is not a risk that people need to face. And if you don't see the gestational sac, come back in a couple of days, get the actual blood levels of the pregnancy hormone. Are those going up? If they're not going up, it still could be a miscarriage. You don't know if it's an ectopic, but you've got some time in that early stage.
Right.
But I was wrong with that patient. I thought, oh, we better do a transvaginal. Sure enough, there was a gestational sac. I was so relieved for her.
Yes.
I said, oh, good.
Yeah. So what I'm taking away from this is the mother's life is always first.
Always first.
The
Absolutely.
Patient, that's your main priority.
Absolutely.
That's always going to be.
Absolutely.
If
they have hypertension,
yeah,
and if their blood clotting system's beginning to fall apart so that they're going to spontaneously bleed and everything, and their platelet count has tanked because of this process going on related to the pregnancy, the immune system, and the hypertension and all of that, a severe form of preeclampsia, the pregnancy has to end regardless of the gestational age. Now, if they're 25 weeks, 24 weeks, even now 22 and 23 weeks, there's a possibility of that baby surviving.
Yeah. Well, my cousin,
so the purpose for ending the pregnancy isn't to make sure there's no surviving baby. The purpose is to save the life of the mother. And that's very ethical.
Yes, that's always
ethical.
Always comes first.
Absolutely.
And so articles like these that skew that type of mentality,
and try to scare women.
It's a political tactic.
Yeah.
And so take these types of articles with a grain of salt. And these are not to dismiss the personal stories, but
no, because they were harmed.
They were
harmed by malpractice.
Correct. That's the glitch, right?
Yep. That's the glitch.
That's the fine print that this article seemed to have left out.
Right.
And
because it's not the law that caused the problem.
Right.
There's nothing illegal about putting that mother's life first. Absolutely nothing.
Yes. So you've heard it, folks. Please, when you read, I encourage you to go check this article out and then listen to this podcast again, because it's fascinating how they use certain words to twist and pretty much land on a certain agenda. And we just want to make sure you have informed consent.
Everything's just getting slanted in one direction.
Yeah.
And people need to think for themselves.
Yes.
We're not judging them.
Yes.
They need to think for themselves. Just keep involved and do your research. Think about these things seriously. Don't just take them casually.
Right. Don't just Google things.
Right. Okay.
Or listen to
letting me throw that in there.
Yeah, or just read a Seattle Times article and then make up your mind.
Right.
You really need to think these things through, because it has lifelong consequences on other people, yourself, other people in your community, and thank you for this conversation. It's been awesome.
It's been kind of fun. Yeah.
Yeah. So, okay, folks, if you have any comments, any questions for Dr. Rutherford, please email it to us. Please give us a call. But these are the types of conversations I think we should have beside what's being mainstream, I guess, what's being pumped in by either the pressures of the election coming up, because these types of words, right? Abortion, ectopic, miscarriage, all these things that are pertaining to real women in our communities are kind of being hijacked. So just let us know what you think. Thanks for listening. And until next time, be well.
For more information about 3W, please visit our website at 3wmedical.org. That's the number 3, the letter W, medical.org. From there, you can learn more information about the services we provide, book an appointment, or make a donation if you'd like to support our mission. You can also call our office at 206-588-0311. That's 206-588-0311. If you like this episode, please share it with others and consider subscribing on your favorite podcast platform so you never miss an episode. Thank you so much for listening, and until next time, stay healthy and be well.